Okay, so let's try to wrap this up. The IPCC Chapter 7 on well-being, health adaptation systems. We looked at many things, and obviously we have to worry about the future of health systems as well, because we are discussing everything in the context of climate change, climate impacts on health, and climate is changing, so impacts are changing, health risks are emerging. Adaptation is all about trying to manage the unavoidables. And we have talked about shared socioeconomic pathways elsewhere in a couple of courses, and in this adaptation course we haven't done that so much, but you can follow up on the other podcasts I have in other courses on climate change and so on. So these are the characteristics of future health systems under three shared socioeconomic pathways, modified from this paper by Sellers and Eby. Christy Eby is one of the big names in the health business. Shared socioeconomic pathways, very briefly, are extensions from the representative concentration pathways which were used in the assessment report 5. We are looking here at assessment report 6, which used shared socioeconomic pathways, so it's going beyond representative concentration pathways and including socioeconomic trajectories for the future, such as sustainability, conflicts, development, which is fossil fuel, using fossil fuels without, with abandon, and other pathways. I'm not doing a good job, but you can look it up. So basic characteristics: SSP 3, 2, and 1. SSP 1 is the most benevolent one in terms of the global warming targets, the additional warming by additional radiative forcing by 2100 in terms of the imbalance between incoming solar and outgoing long wave. So this is proactive, adaptively managed, frequent partnerships, and interdisciplinary in terms of basic characteristics. The SSP2 is in the middle of the road kind of scenario. Actually, it's not exactly. They use these terminologies, middle of the road. So there is SSP 2.6, 4.5, 6.5, 6, and 8.5, I think. So this must be middle of the road. Incomplete planning, new information incorporated as convenient, and occasional partnerships. Okay, and SSP3 is basically reactive. It means it waits till things to happen and then it reacts. Failure to adapt. Siloed information siloed information channels and national governance, and limited partnerships. Leadership and governance, let's go this way now. In SSP3 you have little focus at national and international levels on climate change and health, and minimal planning is conducted, whereas if you do a bit better, planning for climate change and health, but not comprehensive and often sidetracked by other issues. We are kind of on this trajectory because COVID-19, war in Europe, war in Ukraine, and now the Hamas-Israel war, these things begin to put things on the back burner when it comes to climate change and health, of course. But in SSP1 we have strong climate change and health planning apparatus, including health components of national adaptation plans, regional and international partnerships. So here HNAP and NAP are synergized and both are mainstreamed. In terms of health workforce under SSP3, climate change and health not often incorporated into training, few provisions for new training programs or funding for increase in health worker positions in climate change relevant specialties, health disparities are not addressed. If we do a bit better in the middle of the road, climate change and health not systematically incorporated into training, new training programs are there but are insufficient to fill gaps in demand, and limited attention to addressing health disparities. If we do the best we can, then let's say systematic inclusion of climate change and health in worker training, expansion of funding and training, financing and incentive mechanisms to address health disparities. Health information systems. Assessments of vulnerability and adaptation rarely conducted under SSP3, if ever. Information not useful for planning and minimal risk monitoring or research. So basically this is sputtering along, responding only when absolutely necessary, and no planning, no funding for planning or resilience building in the health system or in adaptation to climate change. Vulnerability and adaptation assessments occasionally conducted under SSP2, but generally of poor quality. Early warnings incomplete, fiscal and political constraints on research, which is again what we are in right now. If we can get much better, then we'll be doing vulnerability and adaptation assessments regularly and use them in planning, and robust early warning networks would exist. Research agenda would be focused on vulnerable communities. Moving to climate resilient and sustainable technologies and infrastructure, SSP3 would be facilities sited and constructed without climate considerations incorporated, medical supply chains not modified to address climate risks. But in SSP2, we would have climate cost serves as a key factor in siting and construction, increasing vulnerability of facilities to shocks. So it won't be very resilient, and recovery would be not very quick or back to necessarily prior to the shock state of functionality. Health infrastructure designed to be robust to storms and floods, with redundant systems added to ensure continuity of care under SSP1. Okay, sorry about that. Service delivery policies to manage environmental health hazards generally not followed in SSP3. Care practices not modified to accommodate climate information. Few changes to emergency management procedures. Health inequities worsen under SSP3. So this is a question of how do you choose economic development as a tunnel vision versus worry about climate change, fossil fuel consumption, societal inequities, health impacts, health risks, and so on. Environmental health policies are not robust under SSP2. Marginal improvements in care practices, risk assessments and communications inadequate, and no shift in health inequities. The best case scenario, policies to manage environmental health hazards regularly reviewed. Practitioners review care policies and adjust as appropriate based on local climate and health conditions. Robust communication tools developed. Health service improvement, reduce health inequities. Finally, climate and health financing. Under SSP3, few funds devoted to climate change and health activities, particularly in low and middle income countries. Few, if any, financing partnerships between high, low and middle income countries. Very weak regional and international coordinating bodies due to funding constraints. So you can imagine if another pandemic comes along in this SSP3 scenario, the outcomes are going to be pretty bad. So we have to go back to remember what we said before, that investing in resilience is going to be less costly than managing disasters after they happen. So the co-benefits are always there, but return on investment is tricky when benefits accrue over longer time, because pandemics and other disasters may not happen year after year, so the investments may not be very obvious in terms of their value. So that's always tricky to manage, public finance management and sustained funding, etc. In SSP2, high-income countries generally form robust financing mechanisms. Fiscal pressures in low and middle-income countries constrain their financing abilities. Financial partnerships formed across countries, but financing often not robust. Regional and international coordinating bodies receive inadequate funds. Again, this is kind of what's happening now. If we want to improve, then robust funding streams for climate change and health would be there. Climate change and health activities receive continuing financial support, effective financing partnerships, regional and international coordinating bodies effectively funded. So you can see that implicitly there is the idea of gathering information, sharing information across international boundaries, and having coordinations and financing mechanisms across international boundaries as well. So those are the shared socioeconomic pathways kind of assumptions. How we make that possible is not always obvious, but these are kind of the dream scenarios for the future. We have looked at this before, so let's look at this again before we conclude. 10 components of the World Health Organization's operational framework for building climate resilient health systems, with links to the building blocks of health systems. So here we have building blocks of the health systems, and we have climate resilience on the outside. So you have leadership and governance, health workforce, vulnerability, capacity, adaptation, assessment. So we had vulnerability, capacity, and adaptation assessment mentioned several times along the way. Integrated risk monitoring and early warnings, health and climate research, climate resilient and sustainable technologies and infrastructure, management of environmental determinants of health, climate informed health programs. Remember, we talked about climate informed and risk informed infrastructure, and also food security, agriculture. We'll talk a little bit about water and so on. So here it's the health context. Emergency preparedness and management, and climate and health financing. Within that we have again leadership and governance for building blocks of the health system, health workforce required, health information systems, essential medical products and technologies. Service delivery is important, especially in response to early warnings, and financing sustained, mainstreamed, considered into fiscal policy, and health national adaptation plan and national adaptation plan synergized, as well as both of them being synergistic with the development priorities as well. Okay, so that's something kind of schematic, but still all the components are very critical for actually designing a health national adaptation. This also we looked before, but this is about pathways from hazards, exposure and vulnerabilities to climate change impacts on health outcomes and health systems for vector-borne, waterborne, vector-borne and foodborne diseases. This is under the frequently asked questions of chapter 7, so I won't go too much into it, but we've looked at the hazards, the vulnerabilities and the exposures, determining the risk, and then having climate sensitive outcomes and system impacts interacting with each other and impacting the vulnerability and exposure. Okay, so there is no way out of, we focus a lot on hazards in terms of heat, drought, floods, storms, vector spread, etc. But vulnerabilities require different kinds of data which don't always exist, especially at the granularity in space and time that is necessary. And exposure also requires data like outdoor employment, housing quality, location and local geography, livelihood types, etc., which also don't necessarily exist. So to bring them together to make risk maps and then to track climate sensitive outcomes and look at system impacts in terms of health system, patient loads, emergency responses, costs, food systems and livelihood systems, all need to kind of come together and be very well coordinated with national adaptation plans, which itself has to be well coordinated with the nationally determined contributions to the Paris Agreement and countries' own economic development priorities and plans as well. Okay, so that concludes the IPCC chapter 7 on well-being and health adaptation. We'll come back and look at a few more points, I think, or maybe I'm done with health. Now we'll move to water. Again, I'll use IPCC. Also add a little bit on biodiversity. Okay, so see you in the next section.